Hello, everyone. I'm Dr. Brian Wood from the University of Washington in Seattle. Welcome to the National HIV Curriculum Podcast. This podcast is intended for healthcare professionals who are interested in learning more about the diagnosis, management, and prevention of HIV. As background, the recommended antiretroviral regimens for treatment-naive individuals with HIV have evolved over the years. National guidelines have been updated recently, and today I will be joined by two experts who will discuss reasoning behind the most recent guideline updates and also their experience choosing a first antiretroviral regimen in clinical practice. Dr. Jehan Budak is Assistant Professor of Medicine at the University of Washington in the Division of Allergy and Infectious Diseases. She serves as Assistant Medical Director for the Madison Clinic, our Ryan White-funded HIV primary care clinic at Harborview Medical Center. She also serves as Director of the HIV Pathway through the Internal Medicine Residency and Associate Editor for the National HIV Curriculum. Welcome, Jehan.
Thank you. Hi.
I'm also joined by Dr. Aley Kalapila, who is Associate Professor of Medicine at Emory University. She's a clinical provider at Ponce de Leon Center, a Ryan White-funded outpatient HIV clinic in Atlanta, Georgia, and she attends on the inpatient infectious disease consult service at Grady Memorial Hospital in Atlanta. She also serves as an associate editor for the National HIV Curriculum, and I'm honored to be joined by Aley today. Welcome.
Hi, Brian. Hi, Jehan. Thanks for having me.
It is great to see you both. I'm really looking forward to this conversation. I'm honored that we get to sit and chat together. The focus, as I mentioned, is going to be on initial ART and recent changes to the Department of Health and Human Service guidelines. So let's dive right in. The Department of Health and Human Services, or HHS, guidelines for selecting ART for treatment-naive adults or adolescents with HIV, focusing really first on those who have never received injectable cabotegravir for PrEP. That section was recently updated, and there was a major update to these guidelines. The guidelines panel removed the combination tablet dolutegravir, abacavir, lamivudine from the list of recommended options. So as a first question, Jehan, could you take us through why you think the panel removed that option from first line and why that option has fallen out of favor?
So I think, one, I'm happy to see that it was moved off of the initial start, because I don't know about you all, but I cannot remember the last time that I started anybody on abacavir, lamivudine, dolutegravir. I certainly have patients who are still on it. I remember starting them on it way back in the day, but recently I have not started somebody on it. Practically speaking, I'm not really using it on a day-to-day basis. My understanding of the reasons why it was likely removed from that initial start is, one, sort of logistically, the need for an HLA-B5701 test, which can at best take a week, at worst take 3 weeks to come back. And so before initiating, so especially in the era of trying to start ART as soon as possible, without having that information, it's hard to do that. And then I think my guess is that perhaps more so was the sort of association with cardiovascular disease. I know that's been a thing for a long time, that there have been some big studies showing association with cardiovascular disease, but my guess is that that was the perhaps nail in the coffin of why it's no longer something to start. And I think I personally was also moved by the sub-analysis, if you would say, from the Reprieve study, where they showed that people who used abacavir had, to me, so much more adverse cardiovascular events. And again, I know that there's a lot of association and it's not necessarily causation, but when we have other things and there is so much association with cardiovascular disease, that's my understanding why. I think in the small print it said those two reasons, but my guess would be that it was more so the latter, and as to what led for it to be there.
So sounds like your clinical practice was moving that direction anyway. Aley, how about your practice?
So I agree with Jehan that probably the two biggest factors that I'm aware of, at least, led to the change in the guidelines was because of the need for the HLA-B57 testing, which often takes a while for it to come back. And we're trying to do rapid ART initiation, oftentimes on patients who are newly diagnosed. And then also, of course, the cardiovascular effects of abacavir. I will tell you that it was a regimen that I used to use quite frequently since I've been now in Atlanta for like almost a decade. It's hard to believe how time flies. And, we had a fair number of patients and tenofovir alafenamide was not available. And we see a lot of advanced HIV in Atlanta. We also see a lot of HIVAN in Atlanta, which would preclude the use of TDF or tenofovir disoproxyl fumarate. And so oftentimes I was trying to get a single tablet regimen. that was integrase inhibitor anchored to avoid drug interactions. And so this often used to be a good choice. So I definitely have used it previously, but yes, with the availability now of bictegravir, single tablet bictegravir, tenofovir, alafenamide, emtricitabine, I've kind of fallen out of having to use it again, especially because more so of the need to wait for the HLA-B57 testing to come back before we can actually use it. So that being said, I do think that there might still be a role for it. I don't know, like again, if you have someone with really bad CKD and you can't use TAF, even their GFR is less than 30, and you have some time to wait and they really want to be on a single tablet regimen, you could start with something else and then switch over to, the 3TC Abacavir dolutegravir regimen. And then I think another time that you could consider using it is also to mitigate drug interactions, right? So if you see patients who need to be on a rifamycin for whatever reason, there's issues with a lot of the rifamycins, be it for LTBI or disseminated MAC, with tenofovir alafenamide in particular. And so sometimes this is also a convenient way to kind of bypass that, at least for a temporary period of time, until they have done with the treatment of whatever other thing is causing the drug interaction. So I think those two probably are like the biggest reasons why I would consider using that regimen.
Thanks, Aley. Jehan, what would you add?
I think I was more curious, Aley, as you were talking, was in a TAF era, when was the last time you started somebody on abacavir, lamivudine, dolutegravir?
Oh, hardly ever. Although I think if I think about my inpatient time, probably there have been moments when I have done that to give someone a triple drug regimen that is obviously fully active, that when they don't have other contraindications to being on it. And more often than not in the inpatient side, when I've had to do it, it is because of drug interactions, and combined with plus minus CKD issues, it's come into play.
I appreciate you both outlining your own practice and why it seems that the guidelines panel got away from this 3-drug combination option. I'll share from my own practice. Like you, I have not started anyone on this option for a very long time. There was an era when we were checking B571 on almost everyone, and we were prepared to prescribe this option for almost everyone if any CKD developed. But now with other new options, with all the concerns about the drugs that you both raised, plus it's also a huge pill, and I don't find people tolerate it very well. And now there's such robust data for dolutegravir and lamivudine dual therapy, including in the setting of M1A4V mutation and other things. It's hard for me to come up with very many scenarios where I would reach for this option. So let me turn to, if you're not reaching for that, what do you reach for? And so what I'd really like to hear is what tends to be the first ART regimen you reach for someone who has never taken ART before. Again, someone who has never had cabotegravir as PrEP before either. This list of options is now relatively short. The HHS guidelines really list 3, the bictegravir, TAF, emtricitabine, or FTC option that Aley mentioned, or dolutegravir with TAF FTC, or TDF FTC, or TDF 3TC. And then there's the 2-drug option, dolutegravir lamivudine or dolutegravir 3TC. So practically speaking, how do you make that decision? Aley, will you start?
Yes, sure. So I think in the era of having a single tablet, bictegravir, tenofovir, alafenamide, emtricitabine, it is always my first go-to. It's a single tablet regimen. It's dosed once a day. It's highly potent. It has a high barrier to resistance, all things I look for, and it is pretty well tolerated. And unlike 3TC, ABC, dolutegravir, it is actually a smaller pill. So I think that probably for me is like my first go-to, especially when I have concerns about patients' adherence to sometimes the TAF, FTC plus DOL combination is also convenient. They're 2 small pills once a day, but sometimes I think for patients who have, say they have housing insecurity, unable to store pills in a safe place, I think it's just easier when you to think about you just have to take 1 pill. I've had situations where patients might take one and not the other because they get confused. So I think for all those reasons, that's probably my first choice that I reach for.
Jehan, is your practice similar?
Yes, my practice is quite similar to Aley's. I will discuss with the patient at first, what is it that they're hoping for in a medication, what's important to them, pill burden, pill size, side effects, etc. And then I will give them the three options of bictegravir, TAF, emtricitabine, or TDF, FTC plus dolutegravir, or TAF, FTC plus dolutegravir, and mention the pros and cons of each of these medications. And one of the things that I'm definitely counseling about is the potential for weight gain. And then I kind of sort of see what the patient is feeling based on that. And then we'll make a decision out of one of those three options together with some shared decision making.
Thank you for that, Jehan. How much are you finding insurance approval and cost to be a barrier to your first line option? And how does that play into your decision making around initial ART? Aley, is insurance coverage for BIC/TAF FTC a challenge for you or not an issue?
So that is a great question, coming from a state that does not have Medicaid expansion. And also in the last year, the other thing that I have noticed is that more and more of our patients are being encouraged by my hospital system to sign up for the ACA. And oftentimes they end up getting onto a lower tier plan, which makes this extremely complicated. So in the immediate instance when someone doesn't have any health insurance at all, and it's going to take them some time to get enrolled in the state-funded like AIDS Drug Assistance Program or ADAP, we are able to get a patient assistance application that will sort of be the bridge. And for that, that's pretty easy to get it for BIC/TAF FTC. But once they get onto ADAP, it is on the ADAP formulary. And then for lower tier insurance plans, at least in the recent past, I have not had a terribly difficult time getting it approved. And I think some of that is because it is first line. It hasn't been too complicated to get it approved, or at least to get it through a prior authorization. But yeah, it is something I have to think about like all the time.
Thanks, Aley. Jehan, what's your recent experience with that?
Yeah, I mean, unfortunately, Brian, to your point, this is reality, and a lot of what we have to do is dictated by one's insurance coverage or lack thereof, unfortunately. And as you and I both know, having worked in Washington State up until January 1st, 2023, BIC/TAF FTC was not even on the state formulary. And so we could not give it for any of our patients on Medicaid, which was very frustrating. Now, however, we can. And so I have been offering that switch to anybody who is on a 2-pill combination of either TDF FTC or TAF FTC and dolutegravir versus switching to BIC/TAF FTC. And it's interesting, I don't know about you both in your experience, but I feel like half of people are like, yes, please let me get to a single tablet regimen. And the other half are kind of fine with just their 2 pills. And again, it really is dependent on the patient and the person.
Absolutely. And coming back to just choosing a first ART regimen, if there's no coverage for BIC/TAF FTC, where are you going after that, Jehan? What's your backup option?
My backup options are either TDF FTC plus dolutegravir or TAF FTC plus dolutegravir.
Got it. Thank you, Jehan, for outlining that.
Mm-hmm.
Aley, are you prescribing dolutegravir lamivudine, which is dolutegravir 3TC, a 2-drug combo pill, as a first regimen?
So honestly, no. And for a couple of different reasons. So I see a fair amount of NRTI resistance, and so I'm nervous. I mean, usually it's an M184V, which I know we're going to get to in a couple of minutes. But so I'm oftentimes having to wait for the genotype data. I also see a lot of advanced HIV and a lot of opportunistic infections. So it again gets very challenging because these patients often have very high viral loads, which can also be a contraindication because you can't prescribe it if someone has a viral load greater than 500,000 copies. And I actually also see a fair amount of Hep B co-infection as well. Another reason for why I can't prescribe that. Actually, I think it has been harder in my experience to get the dolutegravir lamivudine regimen approved through ADAP and private insurance. I don't think it's impossible, but I think that also has been a little bit more of a challenge. So I think for all of those reasons, for me personally, it's one of the big reasons I haven't reached for that 2-drug regimen and have just gone straight to BIC/TAF FTC.
Thanks, Aley. And those are great reminders that per the guidelines, dolutegravir lamivudine is an option as a first regimen, but it's recommended to only prescribe it if the viral load is below 500,000. A person absolutely should be confirmed to not have hepatitis B. It would not be a fully active regimen with hepatitis B. And that is one regimen where it is recommended to have your genotype resistance results in hand, which is a very different scenario, as was mentioned, than we usually want to do. We're often reaching for first ART before the genotype results return. So, Jehan, it is an acceptable option, but are you reaching for it as a first regimen?
Never, not yet. And presumably at some point I will, but I'm not there yet. I think you've heard me talk about this before in clinic when we're sitting next to each other. And I think there's just a lot of things we don't know about a person when we first meet them. And for me, if somebody's going to be on a 2-drug regimen, I'd like to know that they're adherent and that they will be taking their meds. And so for me, I've only used those 2-drug oral options for switch and not for start. Plus, I can't do a rapid start on someone if I don't have their genotype. To Aley's point is about logistics. Again, not having started anybody on it, but whenever I'm doing 2-drug oral combinations, I've had issues with insurance coverage for the branded combination, and I've had to separate the two. Yeah, it is what it is.
So it sounds like it is not either of your preferred options for an initial ART regimen, but maybe a consideration for switching later on once the viral load is suppressed. So, Aley, if I can come back to you, we talked about the recommended regimens for most individuals with HIV. There is also a table of other initial regimens to consider for certain clinical scenarios. This includes things like regimens that are NNRTI based, regimens with boosted darunavir, now dolutegravir, abacavir, lamivudine, as we talked about. I'm just wondering, are you ever reaching for one of those options for a first regimen, such as an NNRTI based or boosted darunavir based option?
Again, I think I would probably reach for it if someone had been on injectable cap, for instance, for PrEP, and they seroconverted, then I think that would be an indication, right, to be on a protease inhibitor anchored regimen. I think also in certain circumstances, if I'm trying to keep them on a once a day regimen and you have to give them again, a rifamycin is probably the most frequent time that I have to deal with this situation because we, again, see a fair amount of disseminated MAC. And so dosing of dolutegravir gets a little bit complicated. The TAF issue gets complicated. So I can see why there might be circumstances to avoid drug interactions, particularly where I might reach for one of these other oral options in an effort to simplify the regimen to at least keep it once a day and or keep it as single tablet regimen. And of course, insurance, right? That's the other big thing too. So, but again, most of these times also, I usually would like to wait for resistance data to come back, certainly to use NNRTI anchored regimens. A PI based regimen, if I have to use it, again, because of the high barrier to resistance, and its potency, that's another one I would be happy to do a rapid start if I could not use an integrase inhibitor anchored first line.
Got it. Jehan, I'd like to hear from you if you are ever reaching for those options. And I wonder if you could also reiterate or give more detail into this scenario of if someone has ever received injectable cabotegravir in the past. So let's consider that scenario too. Then what are you reaching for and what do the guidelines recommend?
I'll touch on that first. So Aley was mentioning too that if somebody came in on long-acting injectable cabotegravir for PrEP or pre-exposure prophylaxis and developed HIV, then we would want to use a darunavir-based regimen. So probably TAF, FTC, Kobe darunavir as a single tablet option. And that is also what the guidelines recommend, is that if that happens, there is concern for INSTI resistance. And so thus you would not want to use an INSTI and would use a PI-based regimen while waiting for some more data, i.e. a genotype. So I have not personally been in that scenario where someone has come to me previously on injectable cabotegravir for PrEP, but that's what I would do consistent with the guidelines if I was in that scenario. And then as far as other options, I do offer a doravirine-based regimen up front for someone for whom weight gain is a concern, in which case I would do a single tablet regimen of TDF, 3TC, and doravirine because I think that it is the most weight neutral. I think many of us think that it's the weight neutral. So that is something that I would reach for. That's probably the fourth most common thing I start.
Aley, have you reached for doravirine in that situation before?
I have not yet, actually. I mean, the times I've reached for doravirine, it's because there's been a lot of issues related to resistance. So these are patients who are highly experienced and have now developed integrase inhibitor resistance, and I can't give protease inhibitors or for whatever reason, but I haven't yet considered giving doravirine.
Certainly a controversial area in which we are waiting for more data. And I think this is great to hear some differences in opinion and practice. Sounds like we all reach for similar options for most individuals for initial ART. Sounds like for all of us, Abacavir TAF FTC for its simplicity, potency, high barrier to resistance. It tends to be our preferred option, but then you've brought up a lot to consider in terms of insurance, in terms of the priorities for the individual, in terms of potential side effects, drug interactions. So this is great. Aley, let me just ask you, let's say you start your preferred option, Abacavir TAF FTC, you're starting before the genotype resistance result returns, and then you get the result and there's an M184V mutation. Do you make any changes?
Yeah, this happens very frequently for me in clinical practice. And so I typically don't. I think there was a time when we knew a little bit less about the M184 mutation, and probably early on in my clinical practice, like 10 years ago, I used to intensify the regimen, oftentimes adding on a protease inhibitor. But in now we know, that we have a lot of great data that show that M184V, even though it causes this like phenotypic resistance to 3TC, FTC, it doesn't actually translate clinically. And also we know that it influences sort of the in vitro susceptibility and makes the virus kind of hyper susceptible to drugs like tenofovir. So I think in those cases, we now know that these patients do very well with, as long as your anchor drug is potent. And Abacavir is certainly a very potent integrase inhibitor. And so I don't feel the need to intensify the regimen.
Jehan, I see you nodding your head in agreement.
Yes, I'm vigorously nodding my head. Yeah, I totally agree with Aley. Like, I think in a pre-2019 era, there was concern with use of just 2 nukes and an INSTI with regards to an M184V. But then once we got the Donning sub-analysis that was shared at CROI in 2019, and I just remember that because it was my first CROI, and then subsequent to that, we've had more data, and then including another big RCT with regards, especially like the Nadia trial, which is where we know that we can use 2 nukes and an INSTI with an M184V. What I've taken away from those 2 trials is that you can still fail and develop INSTI resistance, and that it's harder to develop PI resistance. But that being said, I trust them. And so now I think if I were in that scenario and I had somebody viremic coming in, I started them on this, I subsequently get an M184V, I would just say, come back in as you would in a month or so. Let me check your viral load. And then I don't think I would make any changes unless that sort of repeat viral load was still elevated and the sort of viral decay wasn't what I expected.
Great. Sounds like you are largely in agreement on that topic. And I will just add, I do the same. This has been such an excellent discussion. There's more we could talk about, but I really want to thank you both for sharing your time and expertise and for participating in this episode on starting ART. And I look forward to future conversations with you both.
Thanks,
Brian. Bye, Aley.
Bye.
Transcripts and references for this podcast can be found on our website, the National HIV Curriculum at www.hiv.uw.edu. The production of this National HIV Curriculum podcast was supported by Grant U10HA32104 from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the University of Washington IDEA program and do not necessarily represent the official views of HRSA or HHS.